as you know, we recently chose a program. It's tough. It's also really fun to be at this point in your training. So congratulations to all of you for getting here, because it's not a small feat and it took a lot of hard work. So who are we? We're a diverse group of people who are passionate about family medicine. We love taking care of patients of all ages. We're caring people who really feel like it's part of our job to help recruit and train the next generation of physicians. And as a senior resident, as you go through residency, you not only learn how to take care of patients, but you learn how to train physicians that are coming up the pipeline. Like I said, we used to be in your shoes not too long ago. And most importantly, we want you. Really, if you want us, but really we want you to apply and to have interest in our program. And so part of this program is to share with you what we have to offer, but also answer your questions and kind of help you make the right decision for you. And as a disclaimer, this poster does not reflect the political beliefs of St. Vincent, although Canada for president. As hopefully most of you know, but maybe not everybody knows, because I didn't know this when I was starting to look at programs, but the ACGME does lay out specific requirements for all family medicine graduates in the United States. So a lot of the patient numbers are set by the ACGME, and a lot of programs may get above these numbers. But everyone technically needs these numbers to graduate. The exception was most recent graduating class. There were some exceptions made due to COVID issues, particularly I think geriatrics, ER numbers in some cases were forgiven, but we have no idea what this year is going to look like for all of us PPY3s. So information to come. All right. So do you guys have anything to say about the numbers, or want to say anything about how St. Vincent does with these numbers?
I mean, you'll be fine. Yeah. The numbers. There's really no reason to worry. We get plenty of patients coming through clinic, and also our inpatient numbers are pretty good. Yeah. So it's really not.
Yeah, and I would say that the ACGME doesn't have as high a requirement for inpatient numbers for family medicine, but we're a pretty inpatient heavy program, which I think benefits us. I had somebody tell me when I was in medical school that, like, as an outpatient doctor, should that be what you do? The most important decision you make is whether somebody needs to go to the hospital or not, and you learn that by being in the hospital. Like, you have to be around sick patients to learn what is a sick patient, what's not a sick patient. I think that's a real benefit of our programs. We have a lot of inpatient experience.
I think the one area that a lot of residency programs struggle with, of course, are the 65+ numbers. All residency programs have trouble recruiting older patients, and that's just kind of the nature of the beast. But that's an important question to ask programs when you're interviewing, is areas that they haven't met their numbers in recent years, and what they're doing to correct that. Because sometimes it happens, like this year with COVID and everything, there's kind of a good reason for it to have happened. But if it does happen, then they should be taking steps to make sure that doesn't happen in the future, or make sure that you are able to meet your numbers based on the required training that they require. There's also different ways for programs to interpret these numbers. For example, like the participation in a quality improvement project. Some residency programs may require that everyone does individually their own quality improvement project, and some places may require that you present at a conference or something like that. Our program typically does a group quality improvement project as a whole residency. We all participate. The third years do a lot more of the legwork, just because we have a little bit more time on our schedule and flexibility to meet and discuss it. But of course, people are encouraged to do their own patient presentations and present at conferences on their own topics. But so that might be a question that you ask programs about, kind of how they interpret these requirements from the ABFM. The other thing was procedures. Sometimes I look at this list of procedures and I think like those are really the only ones that are required, because family medicine docs do a huge breadth of different types of procedures. So that's I would say most residency programs that I looked at and that are out there are going to offer way more than just this, but make sure that the program that you're applying to, or programs you're applying to, and the ones that you select are ones that offer the things that you want to learn.
Question in the chat.
Oh, is there? What's up? You can read it.
So the question,
I can ask it if you want me to.
what are home visits like? And I personally have not done a home visit, so I don't think I can really answer.
Generally geriatric, home visits count.
Yeah, so
do independent living or assisted living.
assisted living, yeah. So assisted living visits count. So a lot of residency programs are affiliated with nursing homes and have access to assisted living. It's something that our program encourages people to kind of arrange on their own schedule. Probably as a third year is when you have the most amount of time, but a lot of the faculty would be willing to do that.
In other settings.
No.
There was another question asking about hospice visits.
I don't think that we do specifically, unless you were to do, I don't think palliative care elective has that as part of
Yeah,
it.
you have the option to do a palliative care elective the third year, but I'm not sure if that includes hospice. It might include like inpatient hospice, but I'm not sure. 100%.
Yeah, I don't think we've had anybody do outpatient hospice, but the hospital we're attached to, St. Vincent, they have their own hospice program. So it'd be pretty, I'm sure they'd be fine with you setting up a rotation as doing outpatient hospice with them, and you could go with the nurses out to homes. Almost 100% confident that it would not be a problem.
Does that answer your there's a question asking about movie deliveries.
Mhm.
I think 5 is right?
Five.
Yeah, it's not 10.
And actually, I don't think there's an ECGME number for county deliveries. I think it's what your individual program sets.
Oh, really?
I think it's the actual
Okay.
truth. So our program is 5.
Interesting.
And continuities, for those of you who aren't familiar with that term, because I wasn't when I was looking at programs either, so that's technically 3 to 4 prenatal visits. You're present at the delivery, so if it ends up being a C-section, if you scrub into the C-section, that counts, and then you see them for one of their inpatient postpartum days, and you round up them at the hospital. That's the only time that our program actually requires that people round in the hospital on patients when they're not on an inpatient rotation. That's not the truth for all family medicine programs, and if that's something that you're interested in doing, if you want to round on your own patients when they are hospitalized and see them then in the clinic when they come out, that's up to you. But for us, it was social rounding. The inpatient service care takes care of our patients when they're admitted. So 500 programs in the United States, greater than 500. I couldn't even find an exact number now. As of the last couple of years, I think it was 480 in 2014, 2015. So if they all have similar requirements, then does it really matter where you go, or how do you make that decision as to what's the best place for you? Do you guys want to take this one? Okay, are you having a hard time reading?
No, just
So from now on, your training is about work, and I agree. So you basically need to pick a place where you see yourself training. If you want to specialize, you need to look into programs that will allow that to be amenable. If there's certain services offered by one and not by the others, you need to know about. And there's certain skills that I feel like we can position you know, and those core skills, and I guess will differ for each person. And that's another thing that you need to figure out. I guess.
And so to highlight the photos that we've kind of captured here, we have Dr. Bleaky in the middle, who's one of our residents, and then Dr. Feeney, who's one of our new second years, hanging out on the internal medicine service, and up in 3 North, where we take care of our inpatients. That's to highlight, we have a really close relationship with the internal medicine residencies, the OB residencies, the PEDS residency on campus. And so collaborative care is a huge part of what we do at St. Vincent. and our exposure that we get to their didactics and their patients really enriches our experience here. And then this bottom picture is our second year class when they were getting their white coats, their first, at the end of their first week of residency. So always a proud moment. They got on those long white coats that everybody looks forward to having. And then here is Dr. Drambarian, one of the last IMFM. He's a very special individual. I hope you have the opportunity to meet him. We recently had a power outage at our clinic, and Dr. Drambarian, being the tech wizard and the Boy Scout that he is, was very, very prepared with his headlamp and his virtual hotspot that he was sharing with all of us. So a very when you meet Phil, you'll know that's a classic Phil photo. So some important things, to kind of keep in mind again about programs is, do I want about programs when you're looking at them, but then about what do I see my practice looking like after I'm done with residency? Residency is the stepping stone. This is the point in your career where you stop, where it becomes more self-directed learning, where you decide what kind of practice do I want to have and how do I get the skills that will make me successful in that style of practice. And so is that an academic practice? Like, do I want to work at a university and do research and publish and participate at a lot of conferences? Is that really what being a physician is all about for me? And is that what I want for my career? Versus do I want to be, a community faculty at a community hospital? And there's not one that's better than the other. It's just better suited for you and what you want and what your needs are. Rural versus urban population is a huge dividing line in a family medicine. If you decide you want to do everything, you want to be a cowboy physician and do as much as humanly possible for your patients, maybe a rural practice is better for you. Versus maybe you want to be in a more urban setting where your patients have access to all the subspecialists, and maybe you're more interested in treating urban populations, and there are different medical conditions that are more prevalent in the urban population versus the rural populations, and so that's something just to keep in mind for you. And probably the best thing way to make that decision is to kind of look at the rotations that you really enjoy during med school and look at the patients that you really enjoy seeing. And kind of go from there. Local versus coastal, whether you're close to family or friends, or whether you want to go kind of out of state and look for new adventures and that kind of thing. We already kind of talked about access to subspecialists and really the role that the family medicine physicians play in the community where you're practicing makes a huge difference as to what type of training you would get. You want to probably train someplace where family medicine physicians are respected and where people are interested in training family medicine residents. I would definitely say that fits our program. We work with a lot of subspecialists and we rotate through their services, and they treat us very well because they know that we're going to be referring our patients to them, and they want us to be prepared to take care of the patients, to do that first or second step in management before we refer to them. Whether or not you want to do OB and deliveries, that's always a huge dividing factor. Not saying that you necessarily have to have made that decision, but if you know that you want to do that, definitely look at programs that will give you the opportunities to do greater than 100 deliveries. If that's something that you want to do with your practice, or has the option to, sit in on C-sections and see more and be the primary caregiver, run the labor and delivery floor if that's what you really want to do. And then of course, like we talked about opposed versus unopposed programs last month. If you missed our talk, we're technically an opposed program, but we love that we're opposed and we love working with the other residencies. Like I said, it's collaborative. We all think, or at least I feel like it enriches my experience, and all the residents that I talk to feel like it really enriches their experience. I don't know that necessarily needs to make your decision, but it can kind of help steer you in one direction versus the other. Again, I don't feel like we're given less acute patients just because we're family medicine. We're treated just like any other resident when we're on their service, and we are expected to participate just the way that their interns participate when we're interns on their service. So, all right. This was just my disclaimer. Please, please, please don't pick a program just based on high salary, free food at the hospital, or how nice the facilities are. you know, you've worked really hard to get here. A lot of you have made a lot of sacrifices, moved away from your families, had to sacrifice, you know, having children or putting off getting married or things like that. Now is the time for you to think about you and what you want your life to look like. But also, you know, do keep in mind your training, and salary isn't the most important thing. You're not going to be in residency forever, and the extra $1,000 a year probably in long term is not going to make or break your financial situation. So, you guys wanna go ahead?
So sometimes you aren't always sure. Sometimes you aren't always sure what you want, and I wasn't necessarily in that boat, applying for residency because I always wanted to do family medicine. But if that's the case for you, I would look at programs that just give you a lot of opportunities. You know, especially programs that will let you tailor rotations to, you know, things that you're interested in. Look for diverse faculty who have a variety of interests. And also just take a place where you feel comfortable and supported by the people around you. And that's probably one of the most important things, is to be with residents and faculty who are just fun and who have you in mind as you go through the learning process in residency.
Yeah, no one's going to know exactly what they want 100%, you know, coming into residency. But if you have an idea of what you want, make sure that, you know, that program can accommodate that idea and help you work towards that goal. And then if you do make some changes and some decisions along the way that are a little unexpected, you want a program that's flexible enough that can support that and make you feel like you can expand your learning, because we are lifelong learners as physicians, and so fostering that is important.
All right, so talking about kind of the culture of the program, what is culture? What's comfortable? And that's different for everyone. The values of the program, the availability of mentorship within the program, and then if it has any specific affiliations. So whether that be religious, financial, for-profit or non-for-profit status, and then what does the physician payment look like, and who sets the culture, or who represents the culture of a program, the faculty, the residents or the former residents. And then kind of looking, one thing that I really looked at is whether former residents came back to the program as staff or whether they stayed around to either work at the program specifically or work at the like practice in other capacities, whether they stayed at the residency or whether they stayed within a practice that was nearby or within the same group, and then nursing and support staff. So if you can't tell those things, always ask. So one of my questions was, what do the residents of the program do after this? You know, do you have any graduates of your program that stayed around? And a lot of our graduates are staying on a staff, or a lot of the graduates of the program have come back and have stayed on a staff. And Dr. Harris is a graduate of her program, and she's the program director. We have Kim Smith, who's a graduate of our program. Dr. Gabby Aquaro, she's a graduate of our program. We're going to have 2 staff that are coming on this coming year that are graduates of our program. So I think that is a big indicator of, you know, the love that people have for St. B's, and the family medicine program is that a lot of them have come back to stay.
Yeah, I want to say maybe about 50% of our faculty have in some capacity were trained at St. Vincent, or you know, had worked had rotated at St. Vincent at some point.
Henderson, Dr. Ward.
Yeah, Ward. Mm-hmm. So it's a good place to be. Yeah, Luke Berghoff, who's pictured right here, he stayed as on a sports med fellow, and this is his wife, Gabby Aquaro, and she's a part-time staff for us here in the clinic, and then she works actually across the street at a private practice, family med, and then she helps out her dad too, who's a physician as well. And then Arpit actually went back to Illinois, where he's from, to practice, but I think he enjoyed his time here. And then Brandy actually went out to Seattle, right?
Yeah.
Washington. She wanted to do deliveries and all sorts of crazy OB stuff. And so she got the opportunity out there. This is Dr. Henderson. He's one of our community faculty. He's lovely. He always has a good story for us. And he's our resident photographer who his hobby is photography. So he took some of the photos that we have on the. He'll make you do a prostate exam on everybody.
Listen, his photography is rectal exam.
Oh, he's great.
Did you get the anoscope out?
Yeah. So other things you want to think about, like we talked about already, procedures. Like I said, do they offer what you want to learn? Is it part of the curriculum, or is it something that you'd have to go out and find on your own? Things like colonoscopies and some of those and vasectomies are a little bit more obscure, and fewer family medicine docs do them. So you may have to go off campus or find another mentor in the community that would help you do those types of things. If you wanted to do more ultrasound guided procedures, some programs have more access to that than others, if that's what you're into. Some programs do procedure half days or procedure days, procedure rotations, and that's how they meet their numbers. Other clinics like ours, actually, we schedule our own procedures. We run like a private practice. So if you have a patient who comes in and they're like, I really hate this mole, or I'm worried it's cancerous, can you take it off for me? You schedule them for your, next week when you have availability in your clinic, and you can do that for them. So it's kind of nice because you, for lack of a better term, take home what you kill. So you recruit your own procedures, and you get to decide which ones you want to do and which ones, maybe aren't your favorite. For me, I hate circumcisions, and so I avoid them like the plague. Our faculty will make you try at least a couple, but on the flip side, if you really want to circumcise every baby in the hospital, there's plenty of opportunity for you to do that. So I kind of like the flexibility that our program has. They don't make us do colposcopies if that's really not what you want to do when you're done. Family medicine residency is short, and you want to make the most of your time. Inpatient ER training, the biggest thing is the level of acuity. So if you want to go on and either moonlight in an ER when you're done, or if you really want to make urgent care or ER care your primary primary career, you want to make sure that you have the acuity and the experience that requires for you to feel comfortable in that environment. As we talked about last time, we rotated a couple different ERs, including Elwood, if you want to work in a rural ER, and that's a really fun opportunity. Some points you may be the only doc in the building, and that's a different experience for those of us who trained in cities and in larger hospitals. But it's, and again, that's an opportunity. You don't always have to do that. If you're not comfortable with that, there's no requirement that you do that type of training. The other consideration that I thought of, we're all sick of talking about COVID, but it has changed residency programs. Changed some of the rotations and didactics have to be postponed or rearranged. And I think the way that a program responds to COVID may be a good indication of how stable it is and how organized it is and how dedicated its faculty are. So if there are changes that may affect your training, you should ask about that in an interview and say, will I be able to get my numbers? Is there any plans for us to get in the nursing home now that they're not, really keen on having more residents around older people, those kinds of things. So again, a lot of that is in flux, and programs may not be able to answer that for you now. What's the world going to look like in 6 months? None of us really know. But hopefully they have some kind of plans in place, or they're working, to kind of solve some of those challenges that we're facing. And again, if they're not meeting clinic numbers, what are their plans to boost those numbers? All right, Mark, you want to take this one?
All right, so a couple other things to think about. A big part of residency is the learning aspect about it. So I think this breaks down to a couple of different areas. One is understanding that you're always going to learn best from your patients. So making sure that whatever program you go to has the type of patients you want to see, and also has the type of complications you want to see. So there's, like Adriana was saying, there's a big difference between, for example, rural and urban settings. But I would say that you want to be seeing sick patients in residency. Like you want to go somewhere that has a lot of pathology. You want to go somewhere that you're going to be taking care of complicated patients. Because ideally, when you leave residency and you go and you get your first job, it's easier than what you just came through. Like that's what you want to have happen is you get to your job and you're like, oh, this is easy. Like these patients, they go and get their labs done and they do this and that. Like this is a piece of cake compared to what I've been doing for the past 3 years. So I'd focus on asking the residents, like what type of patients are you seeing, both in the hospital and in the clinic. But then there's also just the learning part of residency, so the actual study part. And this goes a lot back to kind of what we talked about with culture, that usually it's the culture of a residency program that's really going to drive this part of the learning. So, like, are there expectations for people to be learning on their own? Like, are you held to a high expectation as a resident? That's a kind of a tough thing to assess from the medical student point of view, especially if you can't kind of get into the program and kind of be around the people. But you can ask residents on your interviews, like, hey, are you guys like reading AAFP journals? Like, what do your lectures look like? And I would say that like you want to see lectures that are like structured around looking at studies. Like, are we looking at evidence-based medicine, or are our lectures more, similar to med school? Because med school is a time for like learning data. Residency is a time for like more critical thinking, and you want to make sure that the residents are doing those things. And then also what's on here is talking about like practice management, career development. I think this is something that we have a really great advantage over some of the other residency programs in that we have a lot of very successful family medicine doctors in our immediate area who graduated from our program and are doing lots of different things. So we have community doctors who are running their own practice, running their own private practice, doing it successfully, have done it successfully. And so they offer a lot of wisdom in that area. And then we have obviously like doctors who went off and did sports medicine fellowships, geriatric fellowships. So this kind of gets back to something that I think is important, which is while you're in med school, identifying like what you want your residency to look like and finding a residency program that can give you that. Because family medicine is such a broad specialty that the residency programs tend to be very broad as well. And like Adriana was saying, you only have 3 years in residency. Like it's not enough time to learn absolutely everything that there is to learn. So you have to know to some extent like what you want to get out of residency, and then you need to find a residency program that will provide you that. Mm-hmm. So again, like if you're thinking, yeah, I want to be doing outpatient medicine, I would love to run my own practice, I'd be looking for programs that have doctors who graduated and are doing that successfully, right? If you have an idea in mind of what you want to do and you're talking to a residency program and they say, yeah, like we haven't had anybody do that, but I'm sure we could figure it out. Like, no, red flag, don't go there. Not because they're a bad program, but like you want a clear path forward to accomplish like what you want to do.
Mm-hmm. Yeah. It's likely, if they say that, it's likely going to require some, if not a lot of work on your part that you probably don't have a lot of time to arrange.
Yeah.
That being said, like I said, not a lot of programs offer colonoscopies and vasectomy training, or but if they have someone that's affiliated with the program or recently graduated, as Mark said, that's doing that, then they should be able to set you up with that person who could make that happen for you.
So, like for example, when I was in med school, one of the programs I looked at was really OB heavy, and they were training all their FM residents to do C-sections, which I thought was cool. Like that's a cool thing to learn, but I had to kind of take a step back and say, all right, what's the likelihood of me practicing in a place that's going to allow me to do C-sections as a family medicine resident? And honestly, it was not that there's no place like that. There are places, but the places that I was most likely going to live were not going to allow me to do that. So then became a little bit of a business decision that, okay, I could spend a lot of time at this program learning how to do C-sections and probably not really be able to use it. Or I could go to a program like St. Vincent, where there's a lot of inpatient medicine, where you're getting a lot of exposure to really sick adults and kids. And that's something that I know I'm going to be able to use every day in my practice for the rest of my life. So that was kind of what like influenced my decision to come here, was that it was just very practical for me. Like I knew that the training I was going to get here was something I was going to use and it's going to be very, just very practical every day going forward.
Do you guys have anything to add to that? Okay.
I said everything.
Yeah, Mark, well said, Mark. Well said. So I just came up with a list of questions that I thought if you were like, I'm overwhelmed, I don't know what to ask in an interview, I don't know, where to start. These were the things that I thought were most important, or things that I, kind of thought about when I was looking at programs. The biggest thing, like Mark just highlighted, are the residents prepared to practice in the fields that they want, and more importantly, the field that I want to practice, and how I want my practice to look like. And then the other one that Rachel already kind of touched on is one of the most important things. If I have a problem or if I don't know something, am I comfortable asking these people for help? Do I enjoy spending time with these people? Because it is only 3 years of your life, but it can be a long 3 years if it's people that you don't feel comfortable with, or people that you can't stand to be around. And that's not a decision that anyone can make for you. It really is just getting to know the faculty and getting to know the residents. And that's going to be really tough for you guys. And I feel for you, not being able to interview in person. So do the best to reach out to any residents that you feel like you have a connection with, or if you have questions, please don't hesitate to email us, talk to one of us. I'll have our emails at the end of the presentation, but let us know if you want more information or need more information or would like to meet somebody from the program, because we can always arrange that. The virtual interviews are not what we really want to do either, but it's just the way, things are right now.
Yeah, and you can always do we could probably do like a one-on-one video chat if you have an area of interest that you're, kind of wanting to explore. And we know a resident who also, if you're more interested in hospital medicine, we could say, oh, we know a resident who does a lot of that, and you could talk about, the experience that's available at St. Vincent for that. Or if you're more interested in OB and what's the delivery experience like here, or whatever your area of interest is, we could see if a resident would be willing to chat with you about that. So whatever you need, we will try our best to get you a little more one-on-one chat time with somebody if we can.
Another thing we didn't really talk about earlier, another good question is like, how's the program changing, and how do the faculty respond to feedback? Do the residents have power to change things? I would say at our residency program, they're always asking for our feedback and try and do things in real time within a couple months if possible, if it's an easy fix. Things about like making sure our schedule is manageable for us. For instance, we had clinic that was scheduled after OB night shifts that were really awful, and we all talked about how awful they were. And finally, we were able to convince the faculty that our clinic numbers were fine and that we could reduce the number of patients we saw. So we weren't seeing 6 patients after working, a full night. That could have been really, really busy after working, 5 nights in a row or something like that. So they were really responsive and adjusted it to something that's much more manageable for us. So they are willing to work with us. And wellness, I think, is really important too, and that's not something that we really talked about here. But making sure that they have some kind of wellness program focused on wellness, and some way of preventing burnout in physicians, because that's something we hear a lot about. But you want a program that's going to be doing something about it as well. And that's a lovely photo of all of our male residents, mean mugging it. For the camera for Dr. Henderson. And for those of you who aren't familiar with St. Vincent, this is our primary care center, Joshua Max Primary Care Center. So this is where our clinic is located. That's where we're all sitting right now. It houses family medicine clinic, OB clinic, internal medicine clinic, peds clinic, as well as a subspecialist area where general surgery comes. I think podiatry comes, urology comes, derm comes a couple times a month. And so it's kind of a one-stop shop for our patients. We have x-ray on site, we have a pharmacy and a pharmacy residency on site, which is awesome. Oh, so helpful. They're lovely. We offer social work and a psychologist who just joined our staff too. If you were at our last meeting, we were talking about Dr. Walters. So far, he's awesome, and he's going to revamp a lot of our psych training for the coming years. He's got a lot of good ideas and is actually taking ideas from residents about where they want their training to go in the psych field, in terms of counseling and smoking cessation and substance abuse and all sorts of awesome topics that he's really excited to explore. So,
and kind of building off of that, something that I know from residents who have graduated ahead of me is if you think you want to do outpatient medicine, they end up doing just a ton of psychiatry work. Especially if you live like anywhere even kind of rural, it's like trying to get patients to see a psychiatrist kind of out in the real world is so difficult that I have friends of mine who graduated and they're the ones who are starting patients on mood stabilizers when they have bipolar, and they're starting all these atypical antipsychotics. So I would, again, if you think you want to do outpatient in any way, I would really try to find some place that you're going to get exposure to that. Ideally, like some place, not to brag, but like St. Vincent, where we have a psychiatrist on staff as well, and we rotate with him, and he's literally like in our same clinic. You can walk out of your patient's room and walk into his office and ask him a question in a matter of 5 seconds. He's a little bit of a curmudgeon, but he's also a that's a big deal. Like that's kind of a specific thing that you can ask programs going forward. Like, what type of exposure do you guys get to these type of drugs?
Yeah, and it's something we had a little period of time where we did not have a psychologist on staff and we were missing one. You know, it was really helpful to have them to refer our patients to and get them plugged in with that service, but then also to help us learn, you know, strategies for interviewing and motivational interviewing and other counseling strategies that we wouldn't really necessarily learn in med school, but that can be really helpful because most people, when they're out in practice, don't have a psychiatrist that they can just phone a friend on. And most people don't have a psychologist at the tip, you know, at their fingertips to ask questions to. So in residency, you want to make sure you have that so you can learn the things that you need to learn. When you go out in practice, you'll be prepared. Do we have questions in the chat?
There was one.
You guys didn't get out of the escape room?
No.
It was complicated.
There were hard hats involved. I didn't know what was going on.
The last question is, with virtual interviews, how do you suggest we get to know the faculty overall? For example, I really don't like interrogative teaching styles.
Sure.
Yeah. What advice do you have about adapting to the different learning styles while in residency as opposed to med school?
Yeah.
That's a good question. I don't know. Is faculty having their own
So
our thing?
our faculty, we're working on scheduling our interviews now, or like making our schedule for interviews to, you know, plug you guys in once you apply. Right now you'll interview with 2 of our faculty, so Dr. Harris and then another faculty member, as well as a psychologist, and then you'll have an interview with residents as well. So those will be kind of the 4 interviews that you'll have on your interview day. But like Olivia was saying, if you have a particular interest in something, for instance, if you reach out to us and say you're really interested in geriatrics, I might be like, oh, hey, Dr. Knox is our geriatrician on staff. Like, let me give you her contact information. Maybe you guys can set up a meeting and talk about, you know, opportunities for Jerry, that kind of thing. I think asking the residents how they feel about their faculty and what kind of training their faculty have had is also a good way to kind of get to know them and the style. Most of the residents are going to be pretty honest with you on interviews because they want people that want to be at their program. Like I said, we want you if you want us. And so we want people who are going to fit in at our program and do well and succeed. Not I don't mean like fit in like look like us and want everything, you know, like to do exactly the same things that we like to do, but fit in more like our skill set and our attitude and our work ethic, and that all kind of melds with the program. I would say we're a pretty relaxed program. We do good work and we work hard, but we're not intense. We don't interrogate people. I mean, Dr. Fletcher, the psychiatrist, interrogates his patients, but he has a very confrontational interview style with his adolescent patients. But he's about the only one on staff who I think acts that way really at any point in time. We're pretty relaxed. Our faculty is very relaxed. Like I said, I would feel comfortable calling them at 2 a.m. if I had a problem and I'm on labor and delivery and I just didn't know what to do, or if I get a patient phone call at 2 a.m. and I don't know what to do. I feel like none of them would be crabby or would make me feel bad about calling them at those hours.
I've called one of our staff, Dr. LaHood. She specializes in addiction medicine, and I've called her with questions when she's not on call, and she's fine with it. Like, she's so willing to help and answer questions for the good of patient care that I know I called her one time on a Sunday night at 11 p.m. and she was like, "Yeah, what questions do you have?" And I felt so awful, but she was willing to help us out for the good of the patient. So no one is mean at this program.
I think maybe a good question to ask would be, like, specifically if you get to talk with the program director, ask them, how do they deal with residents who are struggling?
Mm-hmm.
Because one thing, if the program director tells you that they don't have residents who struggle, red flag, don't go there.
Everybody struggles at some point. Yes.
Right. And so I think asking, like, what is the process for helping residents who struggle? Because one, like, medicine's hard, but there are going to be people who struggle. And two, them giving you an idea of kind of what they have in place to help those people. So, like, I know I can say for us, like, having, now that I sit in on a lot of the faculty meetings, that we spend a lot of time talking about individual residents and what they need and, like, what they need to succeed and how we can help them succeed. So I think that's maybe the best way to really get at it. And don't be afraid to ask them tough questions when you're interviewing. Like, I think most residents and faculty kind of prefer it when you ask them tough questions versus, just kind of like cookie cutter, whatever questions. Because really, like, you guys are interviewing us the same way we're interviewing you. So don't come in like trying to impress people, but like come in trying to decide for yourself, like, okay, like, is this a place that I can fit in, and ask some tough questions.
You want to be yourself, because whoever you are on your interview day is who we kind of see you as. And if you're not acting like yourself, you're going to have to pretend to be that person for the rest of your 3 years, which sounds really exhausting to me. Like, you want to be somewhere where you're yourself and you're comfortably yourself, and that they accept that, they accept you that way.
Mm-hmm.